Hey guys, welcome back to the Foam Frat podcast. In this podcast, we're going to talk about Placenta Previa, but this is just a small section of a larger series that Sam is doing inside studio called Obstetric Iceberg. So, Sam, what was the concept behind Obstetric Iceberg?
Yeah, so it wasn't my idea actually. So I met Demi Wilkes, who has a bunch of experience in high risk OB transport. She's worked in L&D. She's a flight nurse, and I met her at a conference. We were out in California, and she came up to me, and we were talking about content and studio and stuff and the podcast. And she had this idea for OB icebergs, and she was pitching it to me, and it made a lot of sense. And she framed it as with icebergs, there's a bunch of ice below the surface, right? Like you can only see so much that's floating on top, but the majority of it is down below. And she has been teaching these OB topics for a long time. And she's like, that's really the way it is. You can get this surface level knowledge and, just read the basics on placenta previa or something like that. But once you work in the field and you've done a bunch of high risk OB transports and you see this on the other end in L&D all the way through, it's a very nuanced field. There's like a lot of esoteric information that goes into OB. It's like they speak a completely different language. And so we did this whole series. We went through placenta previa, placental abruption, cord prolapse, and as well as preterm labor. And so we'll be releasing these podcasts. And you guys will also see it inside studio is a different version of it. And then we'll release some of this on our YouTube and other social media as well. The framing of this is basically I looked up all the surface knowledge, like pretty much the easy stuff that anybody would be able to look up on OB topics. And I present that to preface the conversation on what the basics are that you should know. And then she takes the deeper points, the stuff that's hidden underneath the water that you'd really only know from working in the field. So, yeah, huge thanks to Demi Wilkes for facilitating these conversations. She was a wealth of knowledge, and I learned a ton from doing these podcasts with her. So, yeah, we'll release them in parts over time.
Yeah, excellent. The stuff that we learn about OB, like you said, the bright, painless bleeding or the dark, painful bleeding, it's very difficult sometimes because there's, like you said, so many nuances to is it a complete abruption? Is it concealed? And you guys talk about here with Previa, I've always thought about what if you had a field delivery or someone who's going into labor in the pre-hospital setting and they've had not great prenatal care. That happens all the time. What if you didn't know they had previa? How would you know that? Maybe you'd see some bleeding, but would you be like, "Oh, we're not doing vaginal exams, like, actually manually, so we're looking to see if we can see anything," but I've always thought about that, like, that could be a real bad situation where you're like, "Okay, they're having contractions, we're gonna deliver this baby." How would you know that they have previa unless you had ultrasound and you could look and you're not doing, like, a digital inspection, so that could be a real difficult situation.
Yeah, and you're not supposed to if you know about the previa. The cervical exams are completely off the table, which is a big point that Demi drives home in this podcast. And you're right, without prenatal care, where they've actually gone through an ultrasound and have this knowledge beforehand, you're really not going to know, and you're just going to have to go off the signs and symptoms of placenta previa. And hopefully that starts well before labor starts, where you're having painless red bleeding and some of these other things match up with placenta previa. And they're not in full blown labor by the time that this occurs, because, yeah, with that placenta in the way, you're just not going to deliver them normally. First of all, the baby's probably in a transverse lie or a breech position because that big placenta is down here and the head is pretty big too, and that usually goes up here. So not only is the fetus probably in an abnormal position, but the cervix is completely blocked. And so the patient's going to need a cesarean section delivery. But the question comes in, how do you manage or temporize that patient in the meantime, which is a lot of what we go in here, which is the diagnosis and then also, yeah, temporizing that patient with intrauterine resuscitation, which is usually pretty standard. But with these different topics that we talk about, there are like little caveats as far as the intrauterine resuscitation goes for each one of these scenarios.
And all the things you do to slow down contractions are the things that make them bleed worse at the end.
It
So
can, yeah. When the abruption episode comes out, that'll be an interesting point of conversation. And it's also a little sticky with placenta previa as well.
awesome. All right, let's get right to it.
All right, so for our first abnormality here, we have placenta previa. And here's some of the surface knowledge that I found on this one, tip of the iceberg. So for the mechanism, I found that the cervical opening is either partially or completely closed off because of that placenta being low lying. And that pretty much prevents the baby from entering the birth canal. And for the occurrence, I found generally it was pretty low, like a 0.5% in pregnancies, but that was if they had never had a cesarean section before. And the number that I found for increasing risk with more cesarean deliveries was if they had 3 or more, that the chances of having a previa came up to almost 40%. It was 37%. And then there's other risk factors like uterine surgery, high parity, multiple fetal gestation. But then the presentation was painless bright red bleeding, could be second, mostly third trimester, no contractions. And then if the bleeding is really severe, they could have signs and symptoms of hypovolemia from hemorrhage as well. And then one of the last things I'll throw in here is that I found this mnemonic, which was Previa. And the P was for painless bright red bleeding, R for relaxed soft uterus, E for episodes of bleeding, visible bleeding, since that placenta is right down by the cervical opening, intercourse bleeding, and then abnormal fetal position, which I found was, I guess you just generally don't have two big things in the same area. So you have the big head, and that typically goes up top into like almost like a breech position. Then you have the big
Mhm.
placenta down below. And then it was just mostly intrauterine resuscitation, left lateral recumbent, oxygen, volume, possibly tocolytic. So that's what I found on my surface knowledge search here. So what else should we know about this?
So a lot of women, they have known from the beginning that they were going to have a either a low-lying placenta or a complete placenta previa. We're most fortunate to know with OB that women who've gone to the doctor early on like they should, they have the most knowledge up front because they're going to have most accurate gestational dating if they went to the doctor early because when the baby is the smallest, that's when it's most consistent. That's when you get out of the genetic or just things with the mom or things with the baby interfering with the growth. So your earliest ultrasounds are the most informative for that kind of things. But a lot of women, they will actually start out with a complete previa, and sometimes it will, as the uterus grows, then the placenta can move up. So there can be
Mhm.
different types of placenta previa. Some women will have bleeding at the beginning of the pregnancy, and the doctor says, "We're just gonna watch it because the placenta's low right now, and it might move up as your gestation goes on." Like you were saying with people who've had multiple C-sections before, one of the risks that we have, and we transport a lot of people for this, is that placenta can actually grow into the scar. And
Mm.
sometimes it's more than just a placenta previa. There's different levels of that growth that could be called an accreta, an increta, or a percreta. And those are often reasons that will transfer a mother to a higher level of care because they have a high risk for a hysterectomy. And those are your women who are going to have massive transfusions in addition to the hysterectomy when they deliver. And in fact, sometimes we'll have an OB/GYN oncologist attend the surgery because it can be such a complicated surgery.
I just have a quick follow-up question
Mhm.
on
Yeah.
the Increta. It was Accreta, Increta, Percreta, right? And so
Uh-huh.
that's like varying levels of how deeply implanted that placenta is into the uterine wall.
Yeah.
Is that appreciable on ultrasound, or how do they find that out?
Ultrasound and MRI. So, like, the accreta is, like, when it's just invading into the uterus itself, and the increta is when it's all the way through, and the percreta, it can grow in actually into the bladder, and so that's where the GYN oncologist can be very helpful because you don't want her to lose her bladder in addition to her uterus. Yeah, it can grow into anything once it's gone outside of the uterus, so, yeah, it's pretty dangerous. And that's where you see your women go into DIC and get lots and lots of blood products beyond what's imaginable.
So with that low-lying placenta, it's not
Mhm.
quite covering the cervical opening, it's just right there. And so
Yes.
you're saying as the uterus grows, that might come up the side like
Mhm.
this and then move further away from the cervical opening, and think that's what they're
Mhm.
watching for?
And so, yeah, so sometimes someone who says they have a low-lying placenta, it might by the time they get to term, it's totally benign.
Gotcha. And so what should EMS providers know about this? So they go out for somebody who's having an OB emergency, or they maybe encounter this person pre-hospital, or they get a transfer for someone who's high risk OB. What
Mhm.
would be must know knowledge for assessing and treating that patient?
Most of the time, your women are going to if they have this condition, they're gonna know, and they've been taught by their doctors, "Tell everybody, no cervical exams. They're already prepared and educated. If I'm bleeding, this isn't good. The thing I want everyone to learn from this podcast is always put your hands on the belly, because there's so many things you can tell from putting hands on the belly. You can tell somebody's potential gestational age. You can tell if they're firm, if they're relaxed, if they're tender, if you can feel if the baby's moving. There's all
Mm.
kind of things you can tell by putting your hands on the belly. So even if you don't even really know what you're feeling, you can tell the difference between hard and soft. You can feel a kick. You can know that if you touch them, it hurts. So that's why I always say put your hands on the belly, because if someone with a previa, if you put your hands on her belly, it's going to probably be soft, as opposed to an abruption who's bleeding, where their belly is going to be firm and they'll probably have some tenderness as well. With the previa, I would say gently palpate their belly and make sure that they're not having contractions, because a lot of times women aren't even aware that they're having contractions if they haven't had a baby before. But the biggest thing is to know that there are no cervical exams done at all on a lady with a previa, because if you go do a cervical exam, you might be sticking your fingers right into that placenta and causing way more damage than any knowledge you're going to acquire from that. And she usually is going to know, but I call it a crackerjack surprise, our lady who didn't have any prenatal care, we don't know what she's got going on. That's why we should always be careful about someone who says they don't have any prenatal care. We don't know what she could have going on. EMS typically is not going to be doing cervical exams, but they typically will lift the sheet and say, "Hey, is there a head?"
Mm.
"Nope." "Is there bleeding?" "Yes or no." "Are we leaking fluid?" "Yes or no." So typically EMS is not going to do cervical exams.
And then for just like this standard intrauterine resuscitation, what does that mean for a general OB department when they say that they're doing that? What do they expect somebody to follow through with?
When you go into intrauterine resuscitation, it means putting them on their left side, giving them oxygen, and giving them an IV fluid bolus, anywhere from 500 to a liter. And all of those things are going to increase oxygenation to the baby. What we typically do in L&D is, if we have a mom laboring or we're watching someone and suddenly we see something that's concerning, maybe on the fetal monitoring strip, or she gives us some kind of indication something's not right, we flip her on her side, we put the oxygen on, and then we'll start the fluid bolus. From the transport world, I would say anytime you're transporting someone, let's do a third of it regardless every time.
Right.
So every single time you do an OB transport, put them on their side. It does not have to be complete hip over hip on their side. I will get a pillow, and even just enough of a tilt is enough to keep them off the vena cava, getting blood returned back to the heart and to the mom, to the baby. That tilt is going to keep that heavier baby off the vena cava, so you're not trapping blood and fluid down below the pelvis, so you have all of your circulating volume. But people are often not mistaught, but they misunderstand that it's got to be complete on their side. It's just got to be a tilt, just enough to shift them off that vena cava. So any OB patient that I transport, and my partners would know this too, we're going to automatically put them on the left side. And paying attention to what meds they have going, because if you have somebody who's got magnesium and they've had a tocolytic, if you start giving them a huge fluid bolus, then you're putting them at risk for pulmonary edema. So we have to be aware of how much fluid they've had before we got there. Because when someone presents to an L&D department, that's the first thing they're going to do. They usually hydrate and sedate and then see what happens. They have a mom coming in saying she's cramping. They put her on the monitor, get her history, give her a bolus of fluid. They'll probably give her some Demerol or something to see if that relaxes her enough to make these things stop. And then only if the baby isn't looking good do they do the oxygen. If we start seeing something on the fetal monitor and VFib, what looks like VFib, we love that. That is good oxygenation, that's good variability, but flat is bad. But what you have to be able to put together with flat is, did we give her a narcotic? Did we give her mag? Because sometimes that will dampen that squiggliness a little bit. A little bit flat is okay, but when you see a absolute straight line, that's ominous. And the absolute straight line is let's deliver this baby. What we want to see is VFib.
Gotcha.
On our if we're traveling along and we're doing our transport and we start seeing some decels or anything like that, then maybe we'll give her 200 mil fluid bolus.
I have one more follow-up question,
Mhm.
which is, does any of this change if there is pretty severe bleeding? Because obviously, at some point, blood products come into play, but does anything with that change if you encounter this person? So let's say you go in for one of the transports and you're like, oh, that's a considerable amount of bleeding coming from this previa. Does that change things at all?
Yes. So if you enter a room and lift up the covers and you see a bed full of blood and you're at a facility that can do the delivery, the challenge is when you go to a facility that's like a standalone ER and you had a mom go in. Like she's going to have to be transported no matter what it is that you see. But if she's at an L&D, you can call the L&D nurse in there and say, "Hey, is this what you saw before?" Because I'm seeing clots. I see a bed full of blood. I don't think that she's safe to make it. I see tachycardia. I see signs of shock. If you see any signs of shock before you leave, then you need to ask the right questions to say, maybe should we think about delivering here? And we'll call the NICU team to have them come get the baby because I
Mm,
don't think this is the best thing for the mom to transport. And
yeah.
your L&D nurse is gonna be very knowledgeable, and she has spent time with the woman, so she's gonna know if it's different. She's gonna know if the doctor saw these things before and is comfortable with the transport. But if you see signs of shock, you need to alert them and say, "Hey, I think we're gonna need to roll right into the OR because this isn't looking good. My mom is becoming hypotensive. You're looking for your signs of hemorrhagic shock." Another thing, because we're gonna talk about planning with all of these calls, and I would say that anytime that you're gonna travel somewhere with a mom flying, you need to know your stops along the way. So if you're going 50 miles and you know that at 25 miles there's a hospital with delivery capabilities, and at another 20 miles there's one with capabilities, you need to keep that in the back of your head because she might start out great and then along the way you see something. And so those are opportunities, even if it's an IFT and you have everything lined up. If it's not looking good, you can absolutely change your course and you have your comm center call that other hospital and say, "Hey, we're not going to make it to hospital Z. We're going to need to stop here because this mom's not going to make it."